So it stands the definition of acute myocardial infarction criteria. And in addition to this, you have a non-obstructive coronaries with normal or mild 30 to 50% obstruction. There's no clinically overt cause for ACS presentation. Pathogenesis varied and leading to uncertainty about the treatment. It occurs upon 6 to 15% of MI, which disproportionately affects the women population. The 4-year rate of males is about 24% and 5 years about 11%. If you look at the comparative cardiovascular risk factors, the woman stands the more common risk factors, and in addition to this, they have a higher incidence of hypertension, history of smoking, apart from diabetes, family history, and hyperlipidemia. The etiological causes are the coronary cause, cardiac causes, and extracardiac causes. You have coronary cause like occult plaque rupture, coronary spasm, spontaneous coronary dissection, embolization, and in cardiac cause you have myocarditis, Takotsubo syndrome, cardiomyopathies, cardiac trauma, tachyarrhythmias, and in extracardiac cause you have pulmonary embolism. So this is the case report of a patient, a 55-year-old female, who had presented with the history of sudden chest pain with the elevated trop-T. And as you can see that there is elevation of ST elevation in the precordial, that is V3 to V5. So the patient was diagnosed as a case of acute myocardial infarction. The coronary shows a non-obstructive coronary arteries, and there was no apparent cause. You can see the left ventricular angiogram was normal. So this came to the working diagnosis of myocardial infarction with non-obstructive coronary arteries. So as you know, there are two types of myocardial infarction, type 1 and type 2. The type 1 has evidence of plaque rupture, thrombosis, erosion, and type 2 is because of systemic and cardiac conditions. The systemic could be sepsis, infectious diseases, and cardiac conditions could be like heart failure, myocarditis, Takotsubo, cardiomyopathies, and other cause like cardiac contusions. So if you look at what are the flow chart of the MINOCA when the patient comes with the universal AMA criteria, you have to go for the non-invasive investigations by doing echocardiogram, and with the invasive investigations you have to go for a coronary angiogram, but sometimes it will not very giving a conclusion evidence. So what you have to do, you have to go for IVS or OCT, and you can go for a pressure Doppler wire to assess for microvascular dysfunction and a provocative spasm test, but it should not be done in case of acute phase of AMI. The laboratory assays are to consider the routine investigations with D-dimer and thrombophilia screening and BNP. So once you come to the diagnosis of etiological diagnosis confirmed by your plaque disruption dissection, Takotsubo. So if the diagnosis is not concerned, then you have to go for cardiac MRI and transesophageal echocardiogram. Now there were two large studies of MINOCA by the European Society of Cardiology Working Group in 2016 and by American Heart Association in 2019. So this was the last study of MINOCA in which 10 studies of nearly 2,000 patients were assessed, and they were found to have ST elevation with MINOCA, and the prevalence of pooled 28 publications showed a 7% overall prevalence. If we look at the comparative prognosis, the Korean AMI registry showed that about 8,510 consecutive AMIs which were categorized into group 3, group 1, group 2 and group 3. It was found that the group 1, that is MINOCA, stand at a better cumulative survival as compared to those patients who had a 1 or 2 vessel or left mainstem obstruction. So this is the flow rhythm, that is algorithm, how you have to evaluate the patient when the patient comes to you with the history of chest pain, looking to the risk factors, taking the electrocardiogram to the cardiology referral. You have to go for the non-invasive evaluation, then go for the functional imaging if the diagnosis is not certain, to go for the myocardial contrast echocardiogram, myocardial perfusion imaging, positron emission tomography, and cardiac, that is CMR. Now this shows the OCT in the plaque rupture. What you see is there is a discontinuity of the thin fibrous cap and there is a rupture site. In thrombosis, that is in erosion, what you see, there is absolutely no gap or defect, but you will see a thrombus across it. In coronary microvascular dysfunction, you see there is an endothelial dysfunction, but there is no documentation of a thrombus such. In spontaneous coronary dissection, it is still a flow obstruction led by the platelet aggravation additions. In Takotsubo syndrome, it is diagnostic only by the left ventricular angiogram when you see aortic ballooning, and epicardial coronary spasm can be seen by the intimal bumping in the OCT. So this is the examples of the MINOCA. You can see in the plaque rupture, you can see the empty plaque rupture and with the evidence of thrombus across it in the OCT finding. And it is an example of the plaque erosion. You can see the blood swirling with the white thrombus and in the red thrombus. This is the example of coronary vasospasm and in the spontaneous coronary dissection. In the coronary spasm, what you see is there is intimal bumping, while in the patients with the spontaneous coronary dissection, you see a true and false lumen. So this is the example of left main, that is the left main we showing a spontaneous coronary dissection, and the OCT showing a cyst cheese appearance of the dissection area. In the CMR findings, unless there is a very intense scar or intense ischemia, you will see a subendocardial with the transmural late gadolinium enhancement with type that is T2 signal hypersensitivity, but in milder case, it will not be very unlikely to diagnose it. So how you will manage Minoka? The assessment is basically by the clinical assessment to see for history of drug abuse, do the angiography and document the spontaneous coronary dissection, spasm, slow flow situation, emboli, or in, suppose if you are diagnosed uncertain, then you have to go for the pulmonary emboli diagnosis, like you have to rule out, do a CTPA and D-dimer, and imaging like CMR will give a confirmed diagnosis, and other thrombophilia profiles can be assessed by this. So if you look at the current management practice, so the pooled study of the 4 AMI registers shows the major amount of the drug is almost the same, it's not much difference. But the role of calcium channel blockers plays a more important role as compared to beta blockers, and in addition you have to give aspirin, clopidogrel and ACE inhibitors. Now we come to INOCA, that is ischemia with no obstructive coronary disease, in angina pectoris which are affecting almost 112 million people worldwide. 70% of the patients undergoing angiography have a normal coronaries, 65% are women, 32% are men, presenting an increased risk of all-cause mortality. The last study was WISE and HARP study, which showed 10-year mortality of 20%. The most commonest cause, as already mentioned to you, the risk factors encountered, and you can see this is the algorithm, how you will approach. You have to go for the non-invasive, invasive investigation, do for the FCA guidewire adenosine test. And this is the brief. The step 1 is coronary angiogram, go for adenosine test, then you go for intracoronary acetylcholine, and then come for diagnosis whether it's a microvascular angina epicardial or microvascular combination of, that is a microvascular with epicardial vasospastic, or it is epicardial vascular, or it is a non-cardiac chest pain. So this is the example of a patient coming with the, that is a coronary spasm, and you can see the right coronary ostia, so totally, there is, you don't recognize the ostia. The post-operative patient, and this is another case. You can see that absolutely the right coronary artery is normal. This patient came. This patient, this angiogram shows normal coronaries. So, ladies and gentlemen, take-home message: Minoka and INOCA are the heterogeneous diseases. Identifying the cause is of utmost importance for the effective treatment. CMR, OCT, IVS, and left ventricular angiograms are essential tools associated with the high mortality and morbidity, hence incurs a higher health cost. There is an immense need for the randomized controlled trials on prevention and treatment. With this, ladies and gentlemen, I thank you very much for the kind attention, for the silent listening. Thank you, Chairperson, once again.